I think we'll just get started now since we're already running a little bit behind, and I think anyone who wanted to join would have had plenty of time. So welcome to week 12. Good job for making it this far. And this one is a pretty quick one because we've only got one lecture to cover this week. We're just going over pharmacokinetics. So it should be pretty easy stuff. Right. So the learning objectives for this week, we've got describe the basic principles of pharmacokinetics relating to drug absorption, distribution, metabolism, and excretion. Explain the advantages and disadvantages of the different routes of administration. Discuss how a knowledge of pharmacokinetics of a drug is important when considering the route of administration, the dosing schedule, and ways of achieving therapeutic levels while avoiding toxicity. And then explain the terms pharmacokinetics, therapeutic index, bioavailability, half-life, clearance, plasma protein binding, biotransformation, first order kinetics, zero order kinetics, and induction of liver enzymes. So firstly, what is pharmacokinetics? I think you've already done a lecture on pharmacodynamics. So if you remember back to that, that's the description of what the drug does to the body, whereas pharmacokinetics is kind of the first phase, what the body does to a drug. So that's like a key distinction that it's important to remember. If you remember, pharmacodynamics has a D, so it's the drug first. So pharmacodynamics is drug to the body, whereas pharmacokinetics is body to the drug. I don't know if that made any sense, but that's how I remember it. We've got 4 different stages of pharmacokinetics. So absorption, distribution, metabolism, and excretion. And we're going to go into more detail into those 4 steps next. So routes of administration, this is kind of before you even get to absorption. This is how the drug enters the body. We've got oral, so that's like pills, tablets, injections. When you inject a drug, it can either be intravenous, intramuscular, or subcutaneous. And these have a rapid onset because they hit the bloodstream straight away, especially in intravenous, not in the other 2. Sublingual, that means under the tongue. So this goes straight to the vena cava, avoiding the acid and gut enzymes. So again, that can act faster. We've got rectal administration, which is also rapid because there's mucous membranes there, which it can be absorbed into. Intravaginal, intraurethral, transdermal, inhalational. So that's like, for example, asthma puffers. Intranasal and topical. So that's like a gel or a cream that you just apply to certain parts of your skin. Which route to use? So there's a lot of things, factors that go into deciding which type of administration you're going to do for a particular drug. Oral is obviously the most popular. If you think of most medications, they're usually pills or tablets. That's just because it's easier to take, so you'll have a higher patient compliance. However, sometimes this isn't suitable, and some of the reasons why this might not work would include a drug that is inactivated by strong acids in the gastrointestinal tract. So because anything you take orally has to travel through your stomach, if it's a certain type of drug, especially proteins, they can be denatured in the stomach. A vomiting patient, because they won't be able to keep anything down that they take orally. An unconscious patient, because they won't be able to swallow anything. A patient whose GIT absorption is limited, so that could be for different reasons, different disease states. But if their GIT isn't absorbing things properly, then the blood isn't going to get, the drug isn't going to get into the blood. And then we have a drug that has systemic adverse effects. So this means if it's highly toxic to the body, then you only want to put it in the smallest area possible, so only where you need the drug. So you don't want to take it orally and then it'll travel around your whole body. You want to apply it only to the area of the body you need it. So in such cases, a different route will be chosen. So now we're going to discuss absorption in a bit more detail. So we've got a few different factors that affect the absorption of a drug. So the stage of absorption overall describes a drug's movement from the site of administration to the site of action. And the different factors which can impact this include the form of the drug. So they can be in tablets, suspensions, creams, slow-release capsules, and that'll change how much time it takes to be released. We've got dispersion and dissolution from form. So again, how long it takes to come out of that form. Lipid solubility and molecule size. We're going to talk about those next. Crossing the plasma membrane. So lipid-soluble drugs can passively diffuse straight across the plasma membrane. So like in the diagram to the right, they can just go straight through there. Whereas hydrophilic drugs have to travel through aqueous channels or various carrier proteins to cross the membrane. So those would be like the two examples to the right of the diagram. They can't just passively diffuse straight through. So that obviously takes a little bit longer and there's more effort involved in that. Next, the ionization state. So drugs which are weak acids or bases can exist in an ionized or an unionized form in solution, and only unionized or uncharged drugs can readily cross the plasma membrane because they're non-polar. And if you think back to the basics of like cell transport, usually only non-polar molecules and also lipophilic molecules can cross the membrane easily. So in this little diagram, which is stolen straight from the lecture notes, you can see the two states that are circled in green. So for a weak base, there's B, and a weak acid, you've got AH. So those are representing the unionized forms of those acidic and basic drugs. And those are the only ones that will be able to cross the plasma membrane. We've got the pKa value of a drug. So that's a term that you'll need to know. That means the pH at which it will be 50% ionized and 50% unionized. And so the way that we use this is it'll tell you whether the certain form of a drug will be ionized or unionized. So for acids, if you're at a pH that's lower than the pKa value, then most of it will be unionized. If the pH is higher than the pKa value, then most of the drug will be ionized. And it's the opposite for bases. These drugs exist in equilibriums. So that means when the unionized form of a drug is absorbed from a compartment, then the equilibrium will shift to produce more of that unionized drug. And we've got those equilibriums in the diagram to the right here, as you can see. Molecular size also impacts on drug absorption. So smaller drugs diffuse across the plasma membranes more readily than larger drugs. Just because of their size, it's easier for them to fit. However, this has a minor impact compared to the lipid solubility and ionization state of a drug. So those are the main two factors that will determine how it can absorb. Molecular size doesn't have the biggest impact. Next, we've got bioavailability. So this term is a measure of how much drug is absorbed into the systemic circulation following administration. And oral bioavailability is affected by a number of factors, including the form of the drug. So again, that's the properties of it and the formulation. Then we've got GIT absorption. So that is affected by pH. It's generally the same in most cases, unless a patient is in a state of acidosis or alkalosis. The surface area, so depending on each individual person's anatomy, different surface area of the GIT tract will make something absorb more readily if there's more surface area. And then the speed of gastric emptying. So that depends on whether the patient's just eaten a meal or not, how fast contents are going to be emptied out of their stomach. Then we've got first pass metabolism in the liver. So we're going to discuss that next, but that's basically what happens before a drug can even be absorbed. It's chopped and changed in the liver essentially, and that affects how much reaches the bloodstream. So sometimes drug absorption is purposely delayed to produce a local effect or a prolonged systemic effect. So to produce a local effect, you want to delay the absorption for as long as possible so that it stays in the original compartment that you put it in, and the drug can have more effect there. Otherwise, if we want a prolonged systemic effect, we don't want it to be broken down so that's for things like anesthetics where you want them to last for quite a long time. Ion trapping occurs when weak acids or bases are trapped in a compartment in their ionized form, and thus they cannot readily cross the plasma membrane. So like I was saying before with ionization states, only unionized drugs can cross the plasma membrane. So if they're already in a compartment and then they're ionized, then they won't be able to leave that area while they're ionized. And that will occur if you have weak acids in high pH environments, and vice versa. So next we've got distribution. So this is the second stage of pharmacokinetics. Drug binding. So this is the distribution of a drug throughout the body. Then this is impacted by binding to plasma proteins and extravascular tissues. That's like organs. So commonly, drugs will bind to plasma albumin, especially acidic drugs, and that's just a protein that travels in the plasma in your blood. This renders them inactive because they cannot cross the plasma membrane to enter cells or the brain while they're bound to plasma albumin. Plasma protein binding also prevents drugs from being excreted and metabolized by the liver and kidneys. So basically, while they're bound to this protein, nothing's going to happen to the drug. It's not going to have any therapeutic effect, and it also isn't going to be removed from the body. Therapeutic index. So this term is the ratio of the dose of a drug producing adverse effects to the dose producing the desired effect. So if we look to the diagram on the right here, the top level with that warning sign, that is the concentration of a drug or the dose at which it's toxic. And then the bottom one with the tick is the minimum amount at which the drug is effective. So you have to reach the bottom line for the drug to actually do anything in the body, but then you don't want to cross the top line. So obviously the larger that window is, the better, because it means there's more room for variations in the dose. Whereas if you had a really small therapeutic index, then you have to be really careful, or else you might overdose the drug. So for some examples, penicillin generally has a high therapeutic index. So that means that it's a really good drug to use because it makes it safer, basically. While many anti-epileptic drugs have a narrow therapeutic index, so that means the exact dosage is critical. So you need to really carefully monitor how much of a drug you're given and how long that drug is going to last in the body so you don't accidentally give too much of it. So this is kind of going off that again. This is a graph that was in the lecture notes. So basically we've got the drug concentration on the y-axis. On the x-axis, we've got the time in hours. So onset of action, you can see that's when it reaches the minimum effective concentration. So the bottom of the therapeutic index. So before that, the drug is in such a small concentration that it's not effective in the body. Once it gets up to that, we say that's the onset of action. That's when you're going to start seeing effects of the drug. Then over time, the concentration will decline again as it gets metabolized by the body. Then, so once we get to the termination of action, that's when it falls below the minimum effective concentration again. Up the top where you see minimum toxic concentration, that's the top of the therapeutic index. So basically you just, again, you want that window to be as large as possible. Next, we've got metabolism. Sorry, that should say factors affecting metabolism. So metabolism of drugs mainly occurs in the liver, but it also happens in the GIT, the kidney, and the plasma. Essentially, metabolism increases the water solubility of drugs so that they can be excreted by the kidneys. So you'll go more in depth into the actual reactions that occur next semester, but the end result of all of these reactions is just to increase the water solubility of these drugs. And if you remember, a lot of drugs have to be lipid soluble to cross the plasma membrane. So now we're like going the other way, making them more water soluble so that they can be removed from the body. The key enzymes which are involved in drug metabolism are the cytochrome P450 enzymes. So that's a large family of enzymes and we call them the CYP450, and there's lots of different ones, which again, you'll learn about later. And they act in two different phases in the liver. So you've got phase 1 and phase 2 reactions, which use different enzymes. But again, the end result is making them more water soluble. First pass metabolism occurs after oral absorption in the liver and reduces the amount of drug reaching systemic circulation from portal circulation. So if you remember when I mentioned earlier, first pass metabolism affects the bioavailability of a drug, because after you take the drug, so after it's administered, it goes through first pass metabolism. And this will basically, it breaks down some of the drug before it even reaches systemic circulation. Portal circulation is like the liver's own circulation. So if there's a high first pass metabolism, then it decreases the bioavailability because less of the drug makes it from oral absorption to systemic circulation, if that makes sense. Next, we're going to look at first and zero order kinetics. So first order kinetics is your diagram on the top there, and zero order kinetics is the one on the bottom. So first order kinetics is like normal kinetics, I suppose, and it means that drugs have a fixed half-life. So just as a refresher of half-life, which you might have covered in chem before, that's the time that it takes for like half the drug, the concentration to be decreased by half. So that's kind of a measure of how long a drug is going to remain in the body for. So in first order kinetics, drugs have a fixed half-life and the rate of metabolism is proportional to their concentration. So if you look at the different colors, we've got the green one, which obviously starts in a lower concentration, and then it goes up until you reach the red, which is the highest concentration. And essentially what that graph is showing is that when you increase the concentration, then the rate of metabolism will also increase. So this just keeps things at normal levels within the body. The yellow window in the middle of that graph is supposed to represent, I believe, the therapeutic index. So that's what you want the drug to remain in to be safe, but also to be effective. In zero order kinetics, there is no fixed half-life. So this means the rate of metabolism is constant regardless of the concentration of a drug. So the reason that this can be an issue is that if you have a drug in very high doses, the body can't speed up at all. It still will metabolize it at the exact same rate. So that means that you can very quickly get out of the therapeutic window and overdose on a drug. Whereas in first order kinetics, if you increase the concentration of a drug, then the body will break it down faster. So you'll like bring it back down into normal concentration, hopefully. The reason that zero order kinetics occurs is that if all of the enzymes needed to metabolize a drug have been saturated, then the body physically can't break it down any faster because there's no more enzymes available. So that's why we suddenly see a constant metabolism, because that's essentially the full capacity of the body to metabolize a drug. So for an example, alcohol displays zero order kinetics in any significant amount. So basically any amount of alcohol you consume, the rate of metabolism is constant no matter how much you drink. Aspirin and phenytoin display zero order kinetics in high doses only. So those are two other examples where you won't see zero order kinetics straight away. It's only if you reach high doses where all of those specific enzymes are saturated, then this will begin to occur. And finally, we've got excretion. So this is the final step. It's how the drug leaves the body. We've got a couple of different sites for excretion in the body. The main pathways include the kidneys. This is where water-soluble drugs are removed in urine, and you'll look at this a lot more in second year. Then we've got the lungs. So this is where gases and volatile liquids are removed in exhalation. Volatile liquids just mean liquids that can become gases. The gastrointestinal tract, some drugs are excreted as bile or feces. And sweat, saliva, mucus, tears, and breast milk, so all different forms of secretions from the body, can also contain traces of drugs. And that's why it's important. Some drugs can't be taken by breastfeeding or pregnant mothers because then they can cross over into the baby through breast milk. So that's all for the pharmacokinetics lecture. It's not too content heavy, I don't think. You go into a lot more depth next semester, but this is kind of just an introduction to pharmacokinetics. So don't stress about it too much. You'll cover all of these concepts a second time. That's it from me today, but I just wanted to say good luck for your first med exams. And if anyone has any questions, either about the content today or about like exams in general, the process of revision, what to expect, I guess, yeah, feel free to ask them now. Otherwise, I'm sure anyone in the PSP team is more than happy to take any questions. So if you're worried about exams or you don't know what to expect, feel free to reach out to anyone, and I'm sure they'll be more than happy to give you some advice. So yeah, I just thought I'd leave it open if anyone wanted to know anything about exams. I'm sure the other two PSPs are also providing lots of useful resources and questions to help you prepare for exams. And I think you're still like 2 or 3 weeks out, so plenty of time to revise. So don't worry if you haven't started yet.